So we all understand the challenges that we face when we are managing heart failure in a diabetic patient. We all understand that diabetes is a vicious circle which includes not just atherosclerotic cardiovascular disease, which can contribute to LV dysfunction, not just hypertension as a comorbidity in these patients, which contributes to LV dysfunction, but a diabetic patient has several metabolic disturbances, disturbed cellular functions, structural alterations, cardiac autonomic neuropathy, RAS activation, and all of these actually contribute to diabetic cardiomyopathy. Having said that, we also understand that for every 1% increase in the HbA1c level, there's a rise of heart failure from 8% to 36%, and the clinical incidence and mortality of diabetes is complicated by heart failure. It's 4 to 8 times higher than as compared to the non-diabetic patients. So heart failure with reduced ejection fraction patient, especially when he has diabetes, carries a high risk of hospitalization as well as mortality. So we understand the challenges that we are facing. One, the incidence is increased. Until recently, type 2 diabetes and heart failure were considered separately. But now we understand that type 2 diabetes, complicated with heart failure especially, is one of the most dangerous diseases, and the combination has to be tackled with astute care. And in fact, the drugs like SGLT2 inhibitors, they are considered more as heart failure drugs because they help the patients all the more if the patient has diabetes. So the challenges are that the therapeutic drugs are limited, hypoglycemic episodes are a matter of concern in a diabetic patient, the conventional drugs are not effective for treatment of diabetes, and we need to have an entirely new gamut of drugs which can be given in cohesion and at the same time taking good care of the hemodynamics and any possible side effects. So the recent ACC 2022 guidelines, they recommend ARNI as the first line of therapy in patients with heart failure with reduced ejection fraction. In a chronic symptomatic heart failure with reduced ejection fraction patient who is in NYHA class or 2 or 3 and who is tolerating an ACE inhibitor or ARB, replacement by an ARNI is recommended. ARNI is also recommended in patients who are hospitalized with acute heart failure, and that is to be done, however, just pre-discharge when the patient is hemodynamically stable. Even ESC 2021 guidelines recommend sacubitril valsartan as the first line of therapy instead of ACE inhibitors in all the HFrEF patients. So, use of sacubitril valsartan is now recommended as a replacement to ACE inhibitors in any suitable patient who remains symptomatic on an ACE inhibitor, beta blocker, and mineralocorticoid receptor antagonist. So, sacubitril valsartan by ESC 2021 guidelines, they have said that we can still consider it as a first-line therapy in a patient with HFrEF. And before I wind up and end, I would like to say that ACC 2022 and ESC 2021 guidelines recommendation in a diabetic patient with heart failure with reduced ejection fraction is that SGLT2 add-on can be done as a first-line therapy in a patient with sacubitril valsartan with heart failure with reduced ejection fraction, especially when the patient has diabetes. So it's a class 1A recommendation. And it's in patients with heart failure and type 2 diabetes, the use of SGLT2 is recommended for management of hyperglycemia and also to reduce the heart failure related morbidity and mortality. So having said that, I would like to end and conclude saying that in a patient who is having heart failure with reduced ejection fraction and is a diabetic, we have an entirely new gamut of drugs which is available. RD is another new drug in our armamentarium. Of course, in an Indian setup, we have drugs like ACE inhibitors and ARBs. Finances are a concern. Tolerance of the drug is concerned, especially in this hot tropical climate that we have, because RD is a drug which can actually, cause hemodynamic instabilities, blood pressures in our patients are borderline. It's not always feasible to start it as a first line therapy. However, an astute clinician can do it step by step. Maybe initiate valsartan in the half dose, keep calling the patient for follow up. So, starting therapies like ARNIs and SGLT needs a lot of patience and regular follow up and titration of the therapy on the part of the clinician. Thank you very much.